That's what I get out of it.
We are live. Here we are with Rebekah Griffith. And you are about an hour south of me, I feel like. I'm up here near Boulder. You're down by Denver-ish.
Yep.
You got an unstoppable lady going. We connected mainly on the Twitters, and turns out we were pretty close to each other. And the big thing we're going to talk about today, for anyone tuning in, is she just launched her new brand of the ED DPT, and that's not erectile dysfunction for the fans of my wife in the sexual side of it. It's the emergency department. Why didn't you go ER? I guess that's not. Oh, I do want to ask that. What is that? It's not accurate to what you do?
Well, so if you work in the emergency department, you know that we don't call it the ER, we call it the department, because it's not a room, it's a department. And you can't really specialize in a type of medicine in a room. So I think the trend in emergency medicine has been to either call it emergency medicine or emergency department. So
but
that's why.
And Anthony Edwards, like we need
I
Julianne
know.
Margulies. Come on. We got to play off of that. But yeah, that's awesome. So the ED DPT, the big thing here is you are a physical therapist as a primary frontline musculoskeletal. A little bit about what that setup looks like. Somebody comes in with 9 out of 10 back pain, and you're right there on call, and they say, Dr. Rebekah, come on over and tell us how that goes.
So there are a couple different ways. If you come into the emergency room by ambulance, you're going to see the physician team first, and then we'll get involved with you after that. But if you come in, if you walk in with low back pain, right now we're doing a pilot program having physical therapists front and center. So you would be triaged and then you'd see a physical therapist directly. So those are the patients that we're able to see pretty quickly and see what we can do to evaluate, treat, and get those patients on to the next step with hopefully a little bit quicker access to care.
Awesome. Yeah. That's a very concise answer. So I know you've also been, we talked about this on some previous calls, and for full transparency, folks, Rebekah and I are in a book club, and
next week.
Next week, I'm still finishing up the book. It's a fun one. But yeah, so out of all that, we talked about it on one of our book club calls in terms of, how prevalent is this in at least the United States of having a PT in the emergency department? How are you familiar with some of the stats? We kind of touched on it.
Yeah, so Dr. Stacy Fruth, she's in Michigan. She did this last year. She did a survey of emergency department physical therapy providers, and it looks like there's about 100 programs in existence that we know of. So there may be more than that. It's just not clear from the data that she was able to collect. And that sounds like a lot, but when you think about it, that's not even really that's just barely 2 per state.
2 per state, yeah.
Yeah. So, and I would really like to see a physical therapist in every emergency department and every urgent care so that we can really help provide the right provider for the right patient at the right time.
Mm-hmm, mm-hmm. And then I'm curious for the PTs out there not familiar, like myself, not that familiar with what that looks like. What kind of setup do you have? Do you have hot packs, electrical stimulation? Do you have TheraBands you're giving them? Just wondering on that side of it is, what does that setup look like? Are you doing hands-on stuff? I know that this goes many different ways. I have my thoughts on what you're doing if I don't in that situation. But tell us a little bit of what that setup looks like.
Well, I think it depends on what the patient's there for, right? So if we're seeing like your 90-year-old grandmother who fell down the stairs and broke an ankle, like we're mostly looking at durable medical equipment, gait training, home safety, making referrals for discharge planning. If you come in with acute low back pain, I have access to some e-stim. I have my hands. I have dry needling that we can provide. We do have access to things like TheraBand, taping. We don't really have any weights or anything like that. We just have the room that we're in and the space that we have and a limited amount of time. So basically what we try to do most is empower the patient on how they can best take care of themselves. So I do a lot of pain neuroscience education. I do a lot of activity modification education. I do a lot of discharge planning, things like that.
Awesome. And so I know here in Colorado, where you and I are, us PTs can order x-rays, imaging, MRIs, even blood work. But I'm wondering in other states where the PT technically license does not allow that, and there's a PT in the emergency room, is that just saying hey, I need to get the orthopedist here, and they need to come and take a look, because I do think there's a yellow flag or a red flag where maybe imaging is warranted, but I can't order it. And so you're saving that step kind of based on our licensure here. But yeah, just in terms of referring out and just the relationships, I'd love to hear you talk about how it works with building those relationships with the ED docs and other folks in the hospital system.
Well, I think my absolute favorite part about working in the emergency department is that it's a team sport. So if you've ever worked in an acute care setting, you know that there are nurses, and then there's the resident or the PA or the nurse practitioner, and then there's like several layers before you get up to, like, say, the attending level. In the emergency department, it's not like that. So the attendings kind of see us as same level colleagues. They call, Dr. Griffith, I would really like your opinion about this patient case. And so it's collaborative care. So just like if they had called the orthopedist and the orthopedist says, hey, I'd like plain films of this view and that view, I can do the same thing. So I would hope that same type of collaboration would be present in every state, whether it's part of their licensure or not. Just like if you were going to refer a patient back from an outpatient clinic to their orthopedist, you can do the same thing. You can come up to the attending and say, hey, I know that this patient is here for hip pain, but I really actually have some concern about like a sacral fracture. Or can we do a CT to make sure they don't have a tibial plateau fracture? And my experience has been that once we established rapport, credibility, and our skill set in this setting, that the physicians are more than happy to listen. They're very collaborative. And working in the emergency department, that's their job, right? Their job is to gather the best evidence from every specialist and the best recommendations, and then make their plan of care based on that. So they're some of the most humble and willing to collaborate providers I've ever worked with.
That's awesome to hear. Yeah. And for anyone not familiar here, again, we're going to, from my kind of sort of outsider perspective of all this, I know that in the military, PTs are able to, again, do all these ordering of imaging, even doing injections and things like that. So it's interesting because we do have the training for it, especially at our doctoral level. And in a lot of states, again, it becomes a matter of who has what financial incentives and things like that, which is why, dry needling is not allowed in other states where I was, California, New York, two of the states where the acupuncture lobby just managed to block us from being allowed to do that. And here in Colorado, we're obviously, again, allowed to do that. So, but my question, again,
lots of hard work by a lot of really amazing people.
There you go. Yes. And that's where the advocacy, we might touch on that in the APTA, except in California, New York, they're still dropping the ball, not doing hard enough work. I'm
not going to stick my foot in that one.
That's okay. I'm just being a little facetious. But my question becomes, what kind of additional training, or did you feel like you needed to do additional training, or are there mandated aspects? Is it the hospital system that's requiring it? Like you need to go and take whatever other courses, whether it's again around imaging or specifically around an emergency medical situation. I was going down the path of athletic training and getting a sports residency so I can be on field. There was that emergency medical kind of system, but a little different. So I'd be curious to hear again what additional things, if somebody wanted to pursue this, they would have to go through. And again, is it different hospital to hospital or state to state?
Yeah, I did take that class that you're talking about, the emergency medical training for a physical therapist, and it was not particularly helpful for what I do. It's a very great course for helping like sidelines and being out in the community. But when you're in the emergency department, you're less of a first responder and more of a first receiver. So you need to have a really wide skill set. And what I usually call it is you need to be ready to practice top of scope. So there shouldn't be things where you aren't willing to do. Like there are some PT clinics that I've been to and they'll be like, oh, well, John only treats the hip and the knee. He doesn't really do shoulders. That is not a thing that really can fly in the emergency department. So you need to be comfortable with vitals interpretation. You need to be comfortable with complex comorbidities, polypharmacy, fall risks stratification, durable medical equipment prescription, anything from like a cane to a wheelchair. Like you need to be able to prescribe all of those things. You need to have a lot of facility with different types of bracing. Some emergency department physical therapists are doing all the wound care. They're doing splinting after fractures, things like that. So you need to have strong orthopedic skills, neurologic skills, medical skills. Differential diagnosis is huge. I tell students, just because they're in the emergency department and they're seeing you does not mean the emergency has passed. So you need to be prepared and ready for this patient to still be emerging as an emergency. So I've had, I would say, far more critical events in the emergency department than I've ever had practicing in the ICU. Even though those patients may be less stable, they're so well titrated and cared for. While in the emergency department, people are still declaring themselves. So you have to really be prepared to act quickly as well. I would say other skills, stress management, time management, and really strong communication skills. And it's not for everybody. But so far, there aren't any really great courses that, well, I shouldn't say that. There are some courses available. They just are not, there's not a lot of them. So we're working towards making better continuing ed options. We're working towards making better preparatory coursework for PTs that want to practice in the emergency department.
Very cool. Yeah. One question that brings up for me, because I've been interested in this for a while, is in terms of imaging, what have you found to be the most useful based on, so again, maybe give us some examples of what kind of presentations people are coming in with. Again, is it often back spasms that are 9 out of 10 or 10 out of 10? That's usually how I talk in an outpatient setting, is like if a 10 is going to the emergency room or department. So when somebody tells me, oh, it's an 11 out of 10, I was like, well, maybe, why aren't you at the department? So some of the things that you're commonly seeing, if you can kind of categorize that, and then the sub question of that is, what have you found? Have you played at all with like diagnostic ultrasound? Is that something that's available to you? Or
we do have physicians that do that. I don't have any training in that, so I haven't done that yet, but it would be a really cool skill to learn, I think.
Yeah, it's something I've thought about doing in outpatient, just to look at like tendon health. And again, a lot of people are like, I'm dealing in this CrossFit space. People are thinking like, oh, do I have a torn rotator cuff? And the chiropractor told me I have a torn rotator cuff. Like, what do I do now? So being able to show that very quickly with a diagnostic ultrasound, the cheapest I've seen them is like $2,000. And it just connects to your iPhone and you can just pop it up right there. And yeah, there's definitely the educational component around that. But maybe coming back to, what kind of general presentations are you seeing? If you can, maybe, top 3 things you end up getting. Is there any themes you can share with that?
Yeah, I would say like just this last Friday, I had several patients who came in with back pain after lifting things. So we'll see a lot of workers' comp related injuries, people coming in after lifting something wrong or getting crushed by something at work, or, we're so close to the airport. So I'll see a lot of like baggage handlers coming in with back pain after things like that. We've had such snowy, icy weather. I'm seeing a lot of sprains, strains from falling on the ice, a lot of vertigo as well. We see a lot of patients come in with, as you know, vertigo is scary.
Yeah.
So that is like one of the top 3 things that we see are patients who maybe wake up with BPPV and are completely incapacitated and terrified. So they come to the emergency room and we're able to help them get moving a little bit better.
What's the basic protocol around the vertigo? Because again, is it the Epley maneuver? Do you go right to that? Is it for those not familiar, it's again, the room might be spinning. You're kind of again differentially diagnosing. Is it true vertigo? Is it BPPV? Is it the room spinning? Are you spinning? Are you just nauseous? Is all these different kind of questions. So I'm curious what again, when do you how quickly do you go to that Epley maneuver to try to release or calm things down? Again, that's where you're trying to reset the crystals in the ear for those again not familiar. I would love to hear also, because my wife had some of those experiences where I was at home with her early on in our relationship and having to try some different things and figure out what to do.
Yeah, I would say that when patients come in with dizziness, the first step is to make sure they're not having anything life-threatening or really dangerous. So they'll get quick screenings to determine, are they having kind of some cerebrovascular event, a stroke, something like that, something that's a little bit more dangerous. So I usually walk people through their history very carefully to try and determine, are we looking at a peripheral vertigo, or is this a central type of issue that we need to get you some emergent care for? So we work through that with the physicians as well. I talk to people a lot about what medications they're taking that might be causing some of it, but really it's back to that age-old adage, like listen to your patient and what they're telling you, because they may not have vertigo. I had a patient last week who came in with ear pain and ear ringing and some dizziness, but with the history, she was really not endorsing any kind of room spinning, any type of typical vertigo. And so we did an oculomotor exam, didn't find any evidence of BPPV or any other type of peripheral vertigo. So she was one that was referred back to the physician team for more of a medical workup to determine what was causing her issues. So we'll do the Epley maneuver if a patient really does have kind of a straightforward BPPV. If they have a peripheral vertigo, we'll talk to the physicians about how can we best help them with these symptoms, and then we get them referred on to a vestibular specialist.
Interesting, yeah. And then that takes me kind of to the next thing. Our first book club we mentioned was Upstream. And I know that's some part of your kind of new mission statement, right? Of the ED DPT. So yeah, tell us a little bit about that concept of Upstream, and how you're incorporating that into your new brand.
Well, so the concept of being upstream, right, is like solving problems before they start. And there's the example in the book of that you and your friend are sitting by the river and a child falls in, and you climb in and you pull the child out and you save them from drowning, and you're like, whew, everything's good now. But then more and more children keep falling into the river, and your friend leaves you and you're like, where are you going? And he says, to stop whoever's throwing all these kids in the water. Yeah. So by the time people are getting to the emergency department, I usually consider them sort of off the waterfall already. So they've fallen into the river, they've gone over the edge, and they need somebody to catch them. Hopefully, that's what we're able to do. And I think the best example of that is that if you are coming in hopefully for your first fall or maybe your first near fall, if I can get you the appropriate durable medical equipment, find you the appropriate follow-up rehab services, help you figure out if there are anything we can change in your environment, your medications, or your personal history to help prevent you from falling. Perhaps we've saved you another emergency department visit. We've helped keep you in your home longer. We've prevented a head injury or a hip injury, and more further downstream medical costs. So there was a retrospective article that was completed with patients who were billed Medicare for a visit in the emergency department for falls. And if they were billed by a physical therapist for an evaluation, they were much less likely to have increased medical costs related to the fall and had decreased follow-up care needs after that. So I think that's one example of how we can get upstream and help prevent worse things from happening.
Yeah, for sure. And just having a PT in the emergency department versus going to a hospital where there is no PT. And obviously for most patients, this is not something they're investigating and like, oh, I know that, General or whatever, Denver General, I don't know. And remind us the name of the hospital you're at if you.
I'm at UC Health.
UC Health, yes.
Mm-hmm.
So University of Colorado Health. But yeah, so instead of, people probably not shopping, and a lot of times you end up going wherever you go, you call 911, you get to whatever emergency department you're closest to you, or that the ambulance that shows up is going to take you to, and they're determining that right on the spot. And I used to be an EMT also, so I'm familiar with that side of it. But yeah, we would just get you to the emergency department, and hopefully, we're doing what we can to keep that person alive or keep them comfortable while we can, and diagnosing and passing on that information. But in terms of cost savings, you mentioned some of the cost savings. I think that's phenomenal. Again, is there any research or numbers you're familiar with in terms of another big thing is the opioid crisis, right? So a lot of times if there is no physical therapist, the nurse or the doctor on staff is going to say, hey, we got to get you out of this pain. Boom, you're getting painkillers versus a physical therapist being there. One of the biggest things I think we know in the profession is we can then say, hey, you don't need painkillers, you need to do X, Y, Z. So in terms of cost savings in the short term, and like you're saying, all the way upstream as much as possible when they show up in the emergency department, are you familiar with some of the numbers? Is there research out there? Is there not enough data yet in terms of some of that?
Well, it's interesting that you asked, because this last week I put together a reference list. So anybody who's interested in starting an ED PT program, if you want to email me or contact with me, I can send you that reference list about references in the emergency department to support this practice. And it's 15 pages long. So the answer is there didn't used to be good data, but now there's great data. So the primary themes of emergency department physical therapy, as far as cost savings go, are that we were really decreasing unnecessary hospitalizations. So prior, if your grandmother, again, fell and couldn't be discharged home, if she's able to see a physical therapist and get the right follow-up care and the equipment that she needs, she can go home and not have to stay in the hospital, which we know can lead to decreased mobility and other things. It's also been shown to decrease imaging, unnecessary imaging, and opioid use. Those are both things that are research backed by both national and international data. So there's so much good information out there. Like I said, there's 15 pages of references. Our international colleagues are blowing us out of the water here, but it's so amazing to see the good work that's being done. There's also a little bit of literature support for occupational therapists in the emergency department as far as function, particularly with patients experiencing homelessness and how they can help those patients as well. So it's definitely a growing area to have rehab services in the emergency department.
Awesome. Are you all right with me sharing? Is it the rgriffith@gmail?
Yep, that's fine.
Yeah. So I'm going to put that up on the screen right now. So if anyone wants to shoot her an email, we'll have that in the show notes as well for anyone listening. But if you're watching, it's right here below me. You mentioned the international colleagues blowing us out of the water. And is that just simple as there's these national health systems in Canada and the UK where, again, because of the way those systems are structured, they're doing a lot more to find probably much more efficient, cost-effective ways to deal with some of these issues that are commonly coming up. Whereas here, and unfortunately, again, the American system is more profit-driven,
reactionary,
CYA, cover your ass. Also, when you mentioned over ordering of imaging, things like that, and saying, hey, let's just get an X-ray, make sure there's nothing more serious going on. Sometimes, obviously, that can be a good thing, but yeah, sometimes it's not necessary. And we have things like the Ottawa ankle rules, let's say. So somebody twists an ankle, and then Dr. Griffith here can say, hey, no, based on these rules, like, you don't need an image, and all you need is a little splint, and we'll keep an eye on this, and this are the things you need to look out for. And now we have pretty good certainty around something that's very well established, very evidence-based, whereas a lot of other medical systems or hospitals that don't have a physical therapist there ready to go might not be able to provide that kind of clear information, clear diagnosis. And again, they're just going to say, here's a pill, here's an X-ray, here's an MRI, like, we're going to take you down the system. And now we just spent an additional X amount of dollars, and we also just delayed your healing possibly by X amount of time as well. So yeah, for anyone, it's an interesting topic too here, because we're talking to consumers, to physical therapists as well. But in terms of the consumer doesn't really get that choice. So, it's not like you get to go to the emergency room and you're like, hey, do you have a physical therapist I can see? Because, I know that I listen to this podcast and I need to,
Hey, it's worth asking, because most hospitals do have physical therapists on staff. So even if they don't have one that's dedicated in the emergency department, I would encourage patients to advocate for themselves and say, hey, I would love to see a physical therapist if that's a service that you have here. Yeah. I'm going to take a drink of water. And, that's all right. And you have to notice that I'm using my giant hospital cup.
Excellent. That is quite the mug. I'm sure PT Pintcast Jimmy McKay would be very proud of that. That looks like a bit more than a pint.
Yeah, it's a big cup, but they're durable.
Is that like a gallon? Is that what that is?
It's like 30 ounces, I think.
Maybe. So coming back to this upstream concept, one of the things I advocate for in the outpatient setting, and I'm trying to find a way to get it much more standardized and or commonplace or accepted, is the concept of an annual orthopedic screening. It's something that we've mentioned the APTA, American Physical Therapy Association, has touched on, but never really pushed hard enough. In my experience, my vision of it, I know, again, there was Shirley Sarman was pushing for it a long time ago, one of the biggest kind of influences in our field, long time. Marilyn Moffitt, who was the president of the American Physical Therapy Association and the World Physical Therapy Association at some point. Some of the superhero women that I know you like to always applaud on social media. But annual orthopedic screening, yeah, how do you feel about that? Do you think that again, really upstream would be something that can help us, again, avoid falls, avoid these things that are common to getting, again, like you said, so many people just showing up, lifting things wrong, and that's not lifting necessarily in the gym. It's just, like you said, baggage handlers, people that should be understanding of how to move better. And that's where we come in. That's our specialty, but something missing in this whole equation.
Yeah. So, I mean, I'm a board certified neurologic clinical specialist. So I'm going to push back on this concept of it like an annual orthopedic evaluation and call it like an annual mobility health
Sure.
evaluation,
I'll agree
because
to that.
the orthopedic is just so limiting. Like, I want to know how your balance is. I want to know how your vision is. I want to know how your muscle extensibility is. I want to know how your bones feel to you. I want to know how it feels when you move. And I think that's different for everyone, right? Like, your mobility evaluation, Bo, is going to be different than, say, like my mom's evaluation. You're moving nicely. You're able to do most of the things you want to do. Whereas my mom is 72 years old and wants to walk more and be more comfortable with community ambulation. So there are going to be different things that we look at, but I absolutely agree that I think it would be a valuable upstream service. I think also looking at the work of organizations like the APA HPT and seeing how they're getting into workplaces and going direct to employers to help manage population health as a whole is an area that physical therapists should absolutely be in. Every time I do see somebody come in with a workers' comp injury, like someone who is like pulling boxes off a conveyor belt in this one position all day, and they can't change the setup, like, what can we do to make that person feel better? I think is a really good way to get at the root cause so that they're not ending up in the emergency department. So I think that's a space that physical therapists absolutely should be in. When we talk about this concept of pretty soon we're going to have too many PTs and not enough jobs, like, I don't believe that. I believe that we need PTs to get into more spaces. We need to fill the preventative health space. We need to fill the occupational health space. And we need to be offering some of those primary care services to patients to help keep their bodies moving well. And even if we do that in partnership with their primary care physician, I think that's absolutely fantastic so that we can keep people going for as long as possible. And like the APTA says, transforming society by optimizing movement.
Yeah, and that's some of the different interesting definitions in my episodes here for anyone who's been following along or wants to go back and listen to other episodes is always, how do we define fitness? And one of the definitions that I really like about fitness is goes way beyond six packs and, you know, booty burn and all that kind of stuff. Booty burn, not a good term in general. But the concept there is and I think I'll give Kelly Starrett, Dr. Kelly Starrett, also a physical therapist, credit here of how useful are you in society. So, you know, again, talking about a grandmother who just wants to be able to ambulate in the community, I would push back on you and say, actually, I think that the assessment, the base assessment, is still going to be at the top tier, the same exact thing that I'm doing as a, you know, relatively healthy, fit 38-year-old of, you know, we have our primal movement patterns, we have our breathing patterns, like you're saying, your balance. You know, I might be able to hold on one leg and do some dynamic stuff for 60 seconds and not fall down. And whereas somebody in their 70s or 80s might only be able to hold for 15, 20 seconds if they haven't been testing that, or even 5 seconds or even 3 seconds. That I'm sure we've seen versions of that. And so it's still kind of I think that the top tier of movement, everyone's bodies and the needs of an Olympic athlete and a grandmother are still the same. Obviously,
Agreed.
again, it's just different grades and things like that. So
might be different testing, and they might need different things. And I talk to people, especially in the emergency department, if they're ready to have the conversation about what I call the 5 areas of physical wellness. I talk to them about nutrition, hydration, stress management, mobility, and sleep. And usually I have them rank like where they feel like they are on a 5 scale on each of these areas and have them start focusing on 1 or 2 of those things so that they can gradually improve their health. And I know you 100% believe in that, like being just a little bit better tomorrow than you were today.
1% better every day.
1% better. And so I think no matter who you are, there's room for improvement. So I really do believe in that. And I think that we need to do more of that education. But I think the other piece that I'm super present to in the emergency department are social determinants of health. So if I have a patient who is experiencing homelessness or who might have a substance abuse issue or, no access to medical care or doesn't speak English, like, there are so many barriers to health for these patients. And we're doing a large segment of the population a huge disservice. And I feel like physical therapy shouldn't be a luxury for people. It shouldn't be something that they've never heard of when they come to the emergency department, but something that's easily accessible for everyone to help improve health.
100%. So how do we do that? How do we accomplish that? I know, again, your brand is taking some of that on, but yeah, what other things can the listeners do, especially if they're physical therapists out there? What can they be doing in their jurisdiction, their cities, states, towns?
Well, I would encourage people, to read up about what social determinants of health are. I'll speak to a number of physical therapists that have never really heard the term. And I think that if we're screening for those, there are outcome measures that we use. There's a really nice article in JOSPT about social determinants of health and how to screen for those properly. But then the next step to that is being prepared to offer resources and actually intervene. It doesn't do much good to your patient if you ask them if they're having these problems, but then aren't prepared to really help them address them. So I'd say that's one step that everybody could take. I also think it's important to just be aware of your community. And everybody talks about the zip code, right? Like your best outcomes of health are most closely tied to the zip code that you live in. So I live in a fairly affluent zip code. I mean, people here can probably get mostly whatever they need if they want, and they can afford to cash pay, and they can afford to have a massage therapist, a chiropractor, a physical therapist, like whatever they might need. But the zip code around my hospital is completely different. And those patients may not know where their next meal is coming from. So being aware of where you practice and seeing what you can do to make your services more accessible to people in those other zip codes.
Yeah, that's awesome. And again, from like my perspective, because I'm a cash-based physical therapist, I go to people's homes, like you're saying, I'm kind of on that higher end of cost. So yeah, is it having kind of discounted versions of that? It's offering I mean, even at the CrossFit gym, you know, because people are paying a decent amount of money for CrossFit, for me to just jump in there, I'm obviously there if they get injured, but it's still trying to work that upstream concept of, hey, I do again, like annual orthopedic or movement screen for, you know, X amount of dollars, where, you know, the cost has to be a factor into that equation. So even maybe lowering that and making it more accessible to other community centers, reaching out, YMCAs, kind of things where there might be ways that we can certainly put our reach a lot further into more needed areas. So I think there's a lot of interesting stuff there. And just on that, I mean, again, when folks are in those situations of the lower income, especially, I'm going to throw out there, and I'm sure you've seen it, unfortunately, is when they do have to go to the emergency room, they're more likely to need to go to the emergency room or department, and also the costs associated with that, assuming they don't have the best insurances, or any insurance, right? And unfortunately, the medical costs in this country are the number one risk factor, or the number one thing that leads to bankruptcy and poverty again. So, you know, being in debt for a long time, especially when we can again start to make small changes and make small educational components that hopefully can again help us avoid a lot of these situations down the line. And again, it's such a big problem. I appreciate that, you know, you're making inroads into changing this pretty big issue. And, you know, I don't know how much of that came from just reading that book, but, or something that was kind of there all along, but yeah, that, the Upstream book, definitely one we recommend, I imagine, both of us. And so,
well, and I think I would love to have a list of PT providers in the community who are willing to take pro bono patients, who are willing to see patients with Medicaid. Those resources are so small. So if you can, like, as you maximize your cash-based practice, are you then able to take patients on a sliding scale? Are you able to do more like that? I would say PT Day of Service is another really good opportunity for PTs to maybe serve in communities they wouldn't otherwise, coming out and doing educational events, serving in your shelters or your community shelters and resource centers, so that you can at least give people some more access to physical therapy or just general health related advice. Yeah,
those are really good ideas, and hopefully folks hear this and jump on some of these concepts and start you know, moving and motivating. And I definitely want to do a little bit more myself as we're talking, so we'll talk offline. But moving over to a little bit of a more fun maybe topic is, and I'm sure you get this a lot, is what's the craziest thing you've had come to you in the emergency department, that if you have a good story there that you can share?
Well, first I would tell you never to ask an emergency provider what's the worst thing they've seen.
Because I didn't say worse, I said crazy.
Yes, so 100%. I get that you didn't say that, but I just want to put that out there as a public service announcement for all of my frontline providers. That's traumatic for people. Yeah. And I have things that I don't want to talk about. I have things that I've seen that I won't unsee. Sure. But I would say I had a patient who came in, and she's invited me to share her story freely. And I've done some case study presentations on it before, but she came in with low back pain. She thought from lifting her granddaughter and then having a rear-ending car accident, kind of your typical low back pain. Like, it seemed like low back pain with radiating pain, L4, L5 distribution. I was able to make some changes with some manual therapy, but she just didn't look well. Her vitals were okay when we began. I got her up with a cane to start because I thought, let's see if we can get you to where you could go back to work. And she was not able to cognitively manage the cane. Like she couldn't do it. And then I put her on a walker and I took her to the restroom because, you know, in acute care, you take people to the bathroom. And while we were in there, she just couldn't figure out like the steps, the hygiene steps. So she like ended up needing like hand over hand assistance. And this was somebody who, when they came in, was like completely oriented. And then as we were walking back, like I'm noticing like this increased work of breathing and just some other things like it didn't add up. Like she had a lot of abdominal distension. I had done an abdominal exam and, you know, I just kind of left it with her like, hey, you know, these are the physical therapy things that I want to work on with you, but I'm going to just talk to the providers a little bit. And God bless this physician because I came out of the room. They had shift changed while I was in there. It was his first day. Never worked with a PT in the emergency department before. And I was like, who are you? And he was like, who are you? And I said, I'm the physical therapist. I'm seeing this patient. Something is wrong, like really wrong with this patient. And he just said, okay. And they did a larger workup. They did more blood work. They did an MRI and they found that she had an abscess on the MRI, a spinal abscess from C5 to T12 on the MRI. And they admitted her at that time. And then overnight, she became unresponsive. And so they took her to the OR immediately. And it turned out that the abscess went from C5 all the way to S2.
Wow.
So they had to clean that whole thing out. She had a chest tube. She went from the ED to the ICU, to the acute care floor, to the rehab unit, to home health, to outpatient, and is now like fine and fully back to work. But they had told her if she had gone home, if they had just said, you know, here's your x-ray was negative, here's some pain medication, she probably would have just passed in her sleep.
Yeah.
And the interesting thing is she doesn't remember any of that.
Wow.
She has no memory of me in the emergency department. She doesn't remember any of it, but she wanted to meet me later. And I didn't recognize her. When I saw her well and healthy, she was so changed and like so well compared to the person that I saw. But I didn't have that baseline of knowing what her normal was because she still looked okay and sounded okay and talked okay. But she just wasn't herself. And her family was also like, there's just something really wrong. In retrospect, she thinks she caused the car accident and that she had been deteriorating that whole time. She thinks it was probably her fault versus thinking it was the trigger of what started it.
Wow.
And it turned out, everybody always asks this, like, what was with the abdominal symptoms? They think she threw septic emboli from her intestines. And that's how the abscess started.
Wow. So
that was probably one of my weirder ones. But that case, I think, is important because that could be any setting.
Right.
That could be you, Bo, like going into home and being like, oh, you had a car accident. Like, let's take a look at your back. So being aware, checking vitals, because she had deteriorated 70% on her pulse ox. She was tachycardic. Like, and that was just pre and post within an hour. A huge change. So making sure you're checking those things and you're aware of people, how they're mobilizing. I've had outpatient PT say, I never would have gone with her to the bathroom. I wouldn't have gotten her up and moved her necessarily. You know, so those are all things that I think are important. Yeah,
vitals are vital. As I forget, there's at least one physio or PT out there on the social medias who's really pushing that message.
Dr. Severin, I think.
Yes, I think that's correct. Rich Severin.
Yep, you got it.
Yep. So he's a big advocate of making sure. Again, a lot of folks do get a little lazy or can get lazy with not checking that stuff in different settings and saying like, yeah, you're fine, you look good. And again, 99.9% of the time might not be a thing, but like you're saying, and that's why I did ask about that kind of the weirdest or craziest story, not the worst. But also because my wife, as a sex and relationship therapist, like, you know, we'll go to a gathering of 20 people and the host will be like, hey guys, the sex therapist is here. And everyone will come and get their questions ready. Like, and it's like, I'm asking for a friend, but you know, is it normal to have a gerbil up your ass like Richard Gere and, you know, that kind of thing. So anyway, that was a rumor. That was a rumor.
Yeah, no, I've never seen anything like that come into the emergency room ever.
I'm not sure if We'll leave it at that. We'll leave it at that. So we will wrap up here unless you have some other closing thoughts, a la Jerry Springer or anything. Anything else you want to share with folks about the ED DPT?
Well, we are here to help you learn how to practice in the emergency department, how to start a program, how to find resources, how to continue your education. And I also want to put a plug out there for people. There is a Facebook group to connect with people who practice in the emergency department. It's called the EPT Facebook group. And there's also one for students. So if you're interested, definitely connect there, and I'm available anytime.
Love to hear it. And we have your email up, and anywhere else folks can find you. I know you just opened your new accounts on Twitter and Instagram as well.
Yep. Twitter, Instagram, Facebook. Someday, if I get brave enough, maybe YouTube.
And TikTok, you're not gonna. That's way down the line. No,
I'm too old for that. I think
No.
I've officially crossed over into too old for TikTok.
Everyone keeps telling me you got to go there, and it's like it's where the kids are, and I'm like, I'm not really, marketing to the kids, but that's all right. I don't want to do the little dance videos where you're like, boo, pop, pop.
Yeah, I don't have enough rhythm for that, and I know that's really saying something.
Yeah, but that could be your own like little thing. You can be the out of rhythm whatever person.
The PT that's completely off, that all the text is over here, and I'm like on this side.
Yeah.
That'll be
even a lot of the folks I see, when I do see some of those videos, I'm like, yeah, they're a little off. They could have done, clean that up a little bit, but that's fine.
That might have been their 500th take, Bo. You gotta give people some grace.
I know, but again, it's if you're doing it and you're trying to be that guy, like you better come correct. Anyway,
Fair
that's fine. But yeah, so appreciate you being on here, Dr. Griffith, and we know where to find you, and hopefully everyone got 1% better. And we're gonna close out with a little more see ya. And we got the book up the book. Everyone, what we're doing, if they wanna jump in, they can reach out to us if they're PT. What was the book? It's Hacking Health.
Hacking Health by David Petrino.
David Petrino. I wonder if Jimmy's going to bring him on as a special guest because he works at the same hospital as him. We'll see. Jimmy, if you're listening.
I can neither confirm nor deny any plans related to that.
I was thinking. Anyway, we'll see what happens. We'll let you guys know. Hopefully got 1% better and you're feeling unstoppable. And next time you have any kind of injury, to look for PT in the ED and not the erectile dysfunction. Anyway, we're going to sign off there.